Hi everyone, my name is Noor binti Shafi'i and I'll present about an article entitled Preliminary Toxicity Analysis of 3DCRT versus IMRT of High-Dose Arm on the Radiation Radiotherapy Oncology Group 0126 Prostate Cancer Trial by Jeff M. Niczewski. So the purpose of the study are to give a preliminary report of clinical and treatment factors associated with toxicity in men receiving high-dose radiation therapy on a phase 3 dose escalation trial, and to determine whether an improvement in overall survival can be achieved with dose escalation. So the method used for this article is Radiation Therapy Oncology Group Protocol 0126 is a phase 3 trial that compares conventional dose, which is 70.2 gray radiation therapy, with dose escalated to 79.2 gray conformal radiation therapy. The toxicity data is collected prospectively by using Common Toxicity Criteria version 2.0 and RTOG or EORTC late mobility scoring systems. So the CTV for this article for this trial is for the 3DCRT technique. They included prostate and entire manual vesicles for the first 55.8 gray and to prostate only for a boost up to 79.2 gray. For the MRT technique, they included prostate and proximal 1 cm of seminal vesicle tissue for the entire of 79.2. So for the study scheme, they used the risk group of Gleason score 6 and PSA 10 to 20 and Gleason score 7 and PSA less than 15. So the treatment used are 3DCRT or IMRT. So they randomized the arm, which is 70.2 gray internal fractions or 79.2 gray in 44 fractions. So the results of this study is for the acute GI or GU toxicity. The figure shows the differences in combined acute GI or GU toxicity. There were no differences in acute grade 3 plus GI or GU toxicities. There were no significant differences in acute grade 2 plus or grade 3 plus genitourinary toxicity rates. The most common acute side effects were diarrhea, proctitis, dysuria, urinary frequency, and urinary retention. So for the late GI or GU toxicity, the IMRT was associated with a significantly lower rate of grade 2 plus acute GI or GU toxicity. Although acute effects are very visible, there have been reports of an association between acute toxicity and the development of subsequent late complications. Patients who had experienced acute grade 2 plus GI toxicity were significantly more likely to have grade 3 plus late toxicity. The development of late toxicity was independent of the racial differences described. The most common late effects were radiation proctitis and rectal bleeding. Small volumes of the rectum exceeding high threshold radiation doses were associated with a nearly twofold risk of late grade 2 plus toxicity. If more than 10% or 15% of the rectum exceeded 75 gray or 70 gray, respectively, patients had a significantly greater risk of late GI toxicity. IMRT have been reported to be associated with a lower rate of late rectal toxicity compared with 3DCRT. The strength of this article is they used relatively uniform treatment patients received on the trial. IMRT patients had a larger high-dose target volumes than 3DCRT patients. This was related to the allowance of a target volume reduction on the 3DCRT cases. Although the magnitude of the volume reduction is small, it is specifically at the anterior rectal wall and base of the bladder. This may impact the expression of GI and GU toxicities. The limitation of these studies are the expression of late bladder toxicity cannot be too recognized because the envelope is too short. So RTIG 9406 patients with intermediate risk disease received treatment to the prostate and seminal vesicles to a dose 55.8 gray, following which the prostate gland was boosted to 79.2 gray. IMRT techniques require two separate treatment plans for this target volume approach, so there's just decided to treat the prostate and proximal 1 cm of seminal vesicle tissue to the study dose. This results in the IMRT patients having a slightly larger higher dose CTV than the 3DCRT patients. So the conclusions for the study is the use of IMRT in the high-dose treatment of men with localized prostate cancer was associated with significantly lower doses of radiation delivered to the rectum and bladder. Lower incidence of acute GI or GU toxicity is associated with the use of IMRT. So that's all for the presentation. Thank you.